Okay, let's get started. And hello, everyone. This is our training session number 5. Today, we have a speaker, Dr. Nadawik. She received her MD from Emory. And also, I believe you have a Master of Public Health, right? From Emory. And Dr. Nadawik also have a PhD degree from University of Texas. She got trained at MD Anderson, and currently she's a professor at the Baylor College of Medicine. She's also director of brachytherapy. Today is a special topic focused on SBRT for cervical cancer. I know, many of cervical cancer are treated with HDR brachytherapy. And so since we are organizing this training session for SBRT, and I think it's good to cover also about cervical cancer, especially for many known the middle income countries, cervical cancer is has a large population of patients. Okay, so you can start.
Thank you so much for the introduction. I'm going to be speaking about SBRT for cervical cancer today. Please feel free to interrupt me on the chat if you have any questions. I have it up, and I will try to address them.
Actually, we see the window screen. It was fine. So will you share a different screen?
Oh, you don't see my...
Yeah, I don't see your slides. It's different window.
Okay, hang on. What do you see?
I see the windows screen. I believe you have dual monitor.
Okay, do you see it now?
Now it's good. Yes.
Okay, good. Okay. So we know that cervical cancer is the fourth most commonly diagnosed cancer and the third most common cancer death in women. It causes 350,000 deaths worldwide per year. And this is the cancer of health disparities, specifically prevalent in medically underserved populations due to lack of access to national HPV vaccination, cervical cancer screening and treatment services, and social and economic determinants based on care of women in countries. 94% of deaths globally are from low and middle income countries. So this is kind of a map of the incidence and mortality of cervical cancer. So we can kind of see the prevalence of the cancer incidence and death in low and middle income countries. So we know that for locally advanced cervical cancer that is too big for surgery, chemoradiation followed by brachytherapy boost is kind of the gold standard. But not everybody can undergo brachytherapy due to access, which we'll talk about in a minute, medical comorbidities, technical limitations. There's a good history of SBRT as monotherapy and boost in prostate cancer. And there is a history of SBRT for other disease sites for inoperable malignancies, lung and brain. As many of you are familiar, there's limited access to radiotherapy and brachytherapy in low and middle income countries. In Latin America, only 3 countries met the International Atomic Energy Agency recommendation of 1 megavoltage machine per 250,000 population, and there was only 1 brachytherapy machine per 2.4 million people for the entire region. Most of these are located in Brazil and Mexico. In Africa, no countries with radiotherapy facilities met International Atomic Energy recommendation for megavoltage machines, and only 1 brachytherapy unit per 15.4 million people available for the entire continent. And in India, there was a deficit of radiotherapy machines. So we know this is an issue, getting access to brachytherapy. I worked in Paraguay for a while, and due to access and brachytherapy issues, patients usually got external beam followed by surgery, which has been shown to increase your second complication compared to external beam plus definitive radiotherapy. So this is kind of a visual representation of the megavoltage machine and the brachytherapy unit. So we can see there's lots of gaps in where we have accessible brachytherapy. So access aside, there are other reasons why patients might not be able to get brachytherapy. So anatomy. So sometimes due to patient's body habitus or the location of the disease is greater in the craniocaudal direction than the length of our needles. Perhaps due to obesity, perhaps due to disease at the fundus of the uterus. And there are patients who are considered technically inappropriate for implantation due to inaccessible anatomy, maybe pubic interference, and there are also medical conditions where patients might not be eligible for brachytherapy, such as the need for interstitial and the inability to undergo general anesthesia due to recent stroke, heart attack, platelet disorders, refractory or poorly controlled bleeding disorders, poor performance status leading to high risk of perioperative death. And there's also the case of refusal. Patients can choose not to undergo brachytherapy due to perhaps a history of sexual trauma and the risk of the surgical procedure triggering that. So I'm not going to read these quotes on the slide, but I'd like you to take a minute and read some of the quotes that discuss the potential risk of post-traumatic stress disorder from brachytherapy. These are direct patient quotes that have been taken as part of the EMBRACE study. So I'll give everybody about 30 seconds to read these. Okay, so some very powerful words. Um, Symptoms of acute stress disorder occurred in 30% of the patients a week after treatment, and actual post-traumatic stress disorder in 41% of patients that lasted 3 months after treatment. So this is real. Brachytherapy can be very triggering and traumatic for patients. So one thing I'd like to make clear here is SBRT is not IMRT. So we did an analysis of SBRT and IMRT using the U.S. National Cancer Database. We looked at patients, 15,000 total patients. 42 received SBRT as a boost, and some received IMRT as a boost, and some received brachytherapy. So as you might expect, patients with SBRT or IMRT had higher comorbidities, were more likely node positive compared with brachytherapy patients. But if you look at the BED comparisons, it was very different. The IMRT patients, the BED, median BED was 64.8 gray. We all know that is not enough for cervical cancer. The SBRT median BED was 76.8, so a little closer to the appropriate dose. So we first did a straight analysis. We did brachytherapy boost compared to SBRT and IMRT boost. And as you might expect, the overall survival was better. However, this overall survival had to do with the comorbidities, which was what we call confounding by indication, which is a fancy way of saying the reason for patients getting the treatment is because of something else. So when we controlled for comorbidities, and we did a matched analysis, matched on comorbidity status. Brachytherapy boost was actually the same as the SBRT boost. So the survivor difference was based on the comorbidities. So we did a univariable and multivariable analysis, and once we controlled for comorbidities, again, there was no difference between the SBRT and the brachytherapy boost. So how do we do this treatment planning? I'll kind of go over this in more detail, but just kind of a general guideline. We get MRI at the beginning of external beam and at the end of external beam. We fuse the pre-external and post-external beam to the SBRT CT simulation. We contour as per Get-Estro guideline per embrace, just like you would for brachytherapy, with the high-risk CTV and the intermediate-risk CTV, and I'll go over that in a minute. We add a PTV expansion of about 2 to 3 millimeters to both the HI-CTV and the intermediate-risk CTV. We boost just and treat just like you would for external beam. I typically do 28 gray and 4 fraction. You could also do 6 gray times 5. We use the EQD2 to determine dosimetric constraints and goals during planning with a spreadsheet. We use the exact same spreadsheet as we would for brachytherapy. And I treat twice weekly on a conventional linear accelerator with 3 millimeter multi-leaf collimation.
By the way, do you really need a 3 millimeter MLC? Probably don't need that. 5 millimeter probably would be good.
Oh, sorry, I didn't catch that.
So do you really need a 3 millimeter MLC?
Yes.
I think a 5 millimeter would be good enough, to be honest.
Okay.
Yeah.
Maybe. I don't know. We treat them on the Linux 3 at Smith, but
yeah, that's 5 millimeter MLC. Yes.
oh, okay.
Yeah.
My apologies. I need to update that.
No
So
problem.
patients are treated with pelvic external beam radiation with a simultaneous integrated boost to the positive node as per embrace. We do a resimulation about the 4th week of external beam in order to not delay the overall treatment time, which, as you may be aware, the overall treatment time needs to be within 56 days. But if you shorten it to 50 days, that buys you an extra 5 gray. So we really try to shorten the overall treatment time package to 50 days. So all patients undergo a bowel prep for the CT simulation as well as every treatment. We place a Foley, we drain the bladder, and we add a normal saline amount needed to move the small bowel out of the way. So maybe 50 cc's, maybe 100 cc's. And I do that for each treatment, so it's very reproducible. I place, prior to the CT sim, I do a pelvic exam and place 3 radio-opaque fiducials in the cervix. I usually try to do about 3 o'clock, 9 o'clock, and 12 o'clock. Or you can kind of place them around the tumor, either way. Sometimes we do a simulation with a vaginal cylinder, if needed to be able to determine where the vagina is. If you simulate them with a cylinder, you need to treat them with a cylinder. I specifically do that if they have vaginal involvement. Oh, I think we have a question. Oh, okay. If they have gas in the bowel at the time, we place a rectal catheter to try to remove the gas. So the way we contour the intermediate risk CTV, which is all pre-treatment pelvic disease that was not dose escalated beyond 55 gray. The high-risk CTV needs to be all residual disease evident on post-pelvic external beam MRI, plus the entire cervix. Remember, you have to treat the entire cervix, even if the patient had cervical involvement, initially. For endometrial cancer patients, the GTV can be the high-risk CTV if there was no cervix involvement, if you're treating definitive endometrial. And the GTV residual is all residual disease evident on post-pelvic external beam MRI. So there's a specific way that you need to contour the organs at risk. This is exactly like how you would contour for brachytherapy. The bladder is the entire organ, including the bladder wall and the neck. The rectum is from the anal verge to the rectal sigmoid junction. The sigmoid has to extend beyond 12 centimeters from the anal verge. And then for the small bowel, you contour the individual loops. So this is kind of an image lifted right from Embrace, kind of showing how you contour. The green line is the MRI at diagnosis. So the left panel is the MRI at diagnosis. And so you kind of contour that. And then the blue is the MRI at the time of completion of external beam. And then the red line is the CTV high risk, which includes the entire cervix. So our treatment plan and goals is the max 2 cc's EQD2, including the SBRT plus the external beam component of the plan. The bladder needs to be less than 90 gray. We aim to get it less than 80 gray. I would say it's very hard to get that with SBRT, so it's usually closer to 90 gray. The rectum goal is less than 70 gray, EQD2. The aim is less than 65 gray to reduce the risk of late vaginal fibrosis. Sigmoid less than 75 gray, aim less than 70 gray, small bowel less than 65 gray. So the HDR CTV cumulative EQD2 need to be between 80 and 85 gray, with the D90 greater than 85 gray. If you have more than 30 cc's of residual disease, your D90 need to be 90. Or if you're treating at 56 days rather than 50 days, that D90 need to be 90. The intermediate risk CTV D90 need to be greater than 60 gray. And we calculate the EQD2 using the alpha beta of 10 for targets and 3 for OARs. And the EQD2 includes 45 gray and 25 fractions. That's what they assume you get. So we'll do a quick case presentation. This is a 52-year-old woman who presented with 2 months of weight loss and vaginal bleeding. She had a 7-centimeter mass and positive put node. She had a significant history of sexual assault and currently living in a safe house to escape her attacker. On presentation, it was estimated that the extent of disease would not be covered by intercavitary brachytherapy. She had significant perimetrial invasion, almost going to the sidewall. I discussed with the patient the possibility of interstitial brachytherapy, and she flat out refused due to the history of trauma. So here is a pre-external MRI. You can see that she had pretty large disease, bilateral perimetrial invasion, and concern for almost rectal wall invasion. Very bulky disease. On the post-external MRI, she had a very good response, about 1 centimeter of residual disease in the posterior cervix. She still had a little bit of abnormality in the vagina on exam. So we did external beam 45 gray. She was node negative, followed by SBRT 6 gray and 5 fractions. The coverage was 100% of 6 gray to 96% of the CTV, and the intermediate risk CTV was 4 gray. So this is kind of what a treatment plan looks like. The red is the entire cervix, plus the little bit of vaginal extensive disease on sagittal view. And you can see she had bladder filling. She had a little more gas in the rectum than I would have liked at simulation. Again, a little more gas in the rectum than I would have liked. And normally I would have placed the rectal catheter to get the gas out. But again, due to a significant history, she declined that procedure. So we use the same BED spreadsheet as we would for brachytherapy. We add the external beam component and look at the EQD2 for the total dosage. So our second case presentation was a 39-year-old who presented to the emergency department with flank pain. She was found to have obstructive uropathy, hydronephrosis, and a pelvic mass. She had a nephrectomy tube placed and a biopsy which showed cervical cancer. The MRI showed bladder involvement, perimetrial involvement, and encasement of the left ureter with a 4.7 cm tumor, abutment of the rectal sigmoid, 2 positive nodes. She completed chemoradiation. However, the post-external beam MRI showed a mixed response. The T2 component actually became larger, and due to maybe fibrosis, inflammation, I don't know, and it became completely encasing the left ureter. So we decided on interstitial brachytherapy, but we were concerned about pubic arch interference. So we sent her to the CT simulator and did a quick CT simulation with her legs up in dorsal lithotomy position to see if that would open her pubic arch to reduce the pubic arch interference. It looked like it did. So we went ahead and did interstitial brachytherapy. So here, the top picture, sorry, the picture to the left is her pre-external beam. So you can see she had pretty bulky disease. However, the picture on the right is the post-external beam. So on the axial view, you can see the T2 component did become larger and more consolidated, and encasing the ureter and invading the bladder. I'm not really sure what the reason for was for disease progression. However, I don't know if you can see my cursor here, but the post-external beam kind of became problematic. So we took her for interstitial. The image on the left is the image of my contour on the MRI of what needed to be my high-risk CTV. So you can see on the axial slice that very, very dense heterogeneous mass. It was kind of like the size of a ping pong ball. This mass was so dense that the brachytherapy needles could not penetrate it. So they hit the mass and went around the mass. So you can see on the right, my interstitial needles, there's none going through the mass. So there's no way I would be able to get dose to the mass. So I had to make the difficult decision to pull the interstitial device and to proceed with brachytherapy. Proceed with SBRT instead, because I knew I would not be able to adequately dose that tumor. So we proceeded with SBRT. You can see the patient had the fiducials in place. She had a pretty significant bladder infection, partially due to her nephrostomy tube, and was on a PICC line with IV antibiotics. And as such, she refused the Foley catheter. So we were not able to have bladder filling. So we treated her with empty bladder. And so you can see there's a little more bowel in the field that I would have liked on the axial slice. Her numbers turned out great. So this is our BED spreadsheet that you can see in the green column. I put the external beam contribution to the plan. And then we add the EQD2 2cc doses for 4 fraction to the rectum, bladder, bowel, and sigmoid. I was able to get rectal doses just under tolerance and bladder doses as well. So I was happy with that plan. So we've done a number of these cases, and we recently published a combined analysis with our patients and the group in Fort Myers, Florida, with Constantine Mance. He's with 21st Century Oncology. We looked at 67 patients who were ineligible for brachytherapy due to medical, technical, or patient refusal. There was a median of 60-month follow-up, so very long follow-up on these patients. The mean B100 for the SBRT was 95%. Mean EQD2 bladder 2cc volumes, 72 gray. So very much within tolerance. The mean EQD2 rectal 2cc dosage was 64 gray. So excellent dosage to the rectum. So the outcomes, post-SBRT complete response rate was 94% based on radiological and physical exam and verified with biopsy if there was any suspicion for disease. The 5-year local control at the SBRT boost site was 90%. Excellent 5-year local control. The failure-free survival at 5 years was 83.1%, and overall survival was 74% at 7 years. At 5 years, sorry. So excellent overall survival. In terms of toxicity, only 2 patients had grade 3 toxicity, and one was urinary frequency, one was vaginal stenosis. There was no grade 3 or greater bowel toxicity. And we looked at quality of life measured by the FACS G scores. 82% of patients had the post-treatment quality of life available, and it was superior at 2 and 5 years compared to baseline. So you can see the image of quality of life here. So as you might imagine, it takes a little dip during treatment, but as of 3 months after, it starts returning. At about a year after, they're back up at their baseline. So, good question. Accurate dose delivery is SBRT. So I use the fiducials, the 3 fiducials for tracking, and we use a cone beam CT, and we make the alignment to the fiducials. So we have the bladder emptying, so the bladder filling typically to a standardized amount of fluid, and then the rectal emptying. So we look on the cone beam CT and we adjust the SBRT treatment of that day. We line it up to the fiducials, and then we look and see what the coverage is to rectum and bladder. There are days where there's too much gas in the sigmoid and it's too high for me to get with the catheter. And if I see that the sigmoid, a bunch of gas is pushing into the high-risk CTV, I will either cancel the treatment for that day or get the patient down, have them go to the bathroom, have them walk around, try to move the gas, and then try again. So I have a very low threshold for canceling the treatment that day if they're just not lining up that day. So that's a good question. So we've recently submitted a combined 3-institution dosimetric analysis. We have 95 patients with 3 institutions, UT Southwestern, our institution, and the group from Florida. We looked at patients with FIGO 2009 stage 1B2 to 4B locally advanced cervical cancer. The most common acute grade 3 toxicity in this group was genitourinary stricture, which was 4%. Now, that may not likely have been caused by us. If you have disease extending past the ureter, it is not uncommon that you can cause a GU structure. There are some people right now that are looking at coming up with dosage to the ureter to anatomically constrain it. The problem is it's hard to identify the ureter, especially if the ureter is involved with tumor. We did have some grade 3 colitis associated with EQD2 doses greater than 87.9 gray for rectum, which is, again, way above tolerance. So we should not be that high for rectum. 62.2 gray for bowel and 96 gray for bladder. So again, if you exceed the brachytherapy tolerances, you do have some toxicity. There was some grade 3 GU structure associated with EQD2 doses greater than 88.5 gray for the bladder, 69.8 gray for sigmoid, and 62.6 gray for the bowel. So again, if you adhere to the tolerances set by Embrace, the patients actually do pretty well. There was a little bit of increased risk of grade 3 fistula associated with the EQD2 of the rectum greater than 96 gray. The rectum should never get that high of a dose, truthfully, and same with the sigmoid. There was a little bit increased risk of fistula associated with PTV larger than 154 cc's, which is a gigantic amount of residual disease. So my guess is that those patients probably had some bladder rectal or sigmoid invasion going on just from the tumor. When you treat the tumor goes away. Sometimes you're left with a fistula. However, the 4-year local control was 89%. So excellent 4-year local control. So we do a good job controlling disease with SBRT. And the 4-year failure-free survival was 59%. So one of the big times we use SBRT is for reirradiation. So if we have patients that get standard of care external beam plus brachytherapy with SBRT or external beam plus surgery, and then they have a pelvic failure. We often use SBRT in that case, or if they have a pelvic nodal failure. So I wanted to go over that a little bit. There's no consensus guideline for GYN reirradiation. So I go by the ESTRO guideline for prostate cancer salvage SBRT because the pelvis is the pelvis. And so if you look at those ESTRO guidelines, they say that the primary treatment dose should always be considered. So the SBRT should be higher with respect to the primary treatment dose. The mean EQD2 for effective SBRT should be about 25 to 35 gray in 5 fractions. Ideally, these patients are at least 6 to 12 months out past the prior radiation. So for GYN, the sigmoid and rectum and bladder max point dose is about 25 gray in 5 fractions. The max cumulative point dosage to small bowel EQD2 is 98 gray, bladder is 120 gray, and rectum is 110 gray. If you have been 6 months past the initial radiation, you can have a dose reduction of 25%. If you've been more than a year past the prior radiation, you get a 50% dose reduction. There are a number of case series with SBRT for GYN reirradiation, prostate reirradiation, and rectal reirradiation. So this is an excellent technique for pelvic failures, for good local control of pelvic failures. So I wanted to talk briefly about an international trial called Interlace, which was actually just published. So this is a phase 3 multi-center trial using weekly induction chemotherapy followed by standard chemoradiation versus standard chemoradiation alone in patients with locally advanced cervical cancer. So they did weekly carbotaxol for 6 weeks followed by standard of care chemoradiation. The median age was 46. They recruited from 32 centers in 5 different countries, including the UK, India, Mexico, and Brazil. There was a little bit more hematological toxicity in the neoadjuvant arm, but it did not affect the patient's ability to complete radiation. So I'd like to do a little case presentation using the Interlace study. So this was a 34-year-old with stage 3C1 or 4A, 4B cervical cancer. She presented in November 2023 with flank pain. MRI showed suspected involvement of the ureter and the base of bladder. The PET-CT showed a possible lung met, but it was too small to biopsy, which is why she's a questionable 4B. She was concerned about starting external beam over the school holidays because she had kids and she had childcare issues. So she elected to start Interlace neoadjuvant weekly chemo to get her through the holidays until she could start her daily radiation. So this is an image of the MRI on the left before neoadjuvant chemo, and then on the right after neoadjuvant chemo. So she had an excellent response, almost a complete radiological response before chemoradiation. And then the last picture is the picture right before brachytherapy. So here's the big question, and this applies whether you're doing brachytherapy or SBRT. What we don't know right now is what should be the CTV intermediate risk. Should we use the pre-neoadjuvant chemo volume or the pre-external beam volume? So if a patient has almost a complete response, what do you use as that intermediate risk CTV? So that's one of the questions that we kind of struggle with, whether we do SBRT or IMRT. But I suspect that some of you may be interested in using the Interlace approach with the 6-week neoadjuvant chemo. It worked very well to kind of shrink some of the bulky tumors so that it's a little more technically feasible to do the boot, whether you do SBRT or IMRT. So quick take-home messages, and I'll leave lots of time for questions. So we've learned today that SBRT is a safe and effective boost modality if you adhere to the constraints that would be adhered to with brachytherapy, and for patients who are not able to get brachytherapy for whatever reason, with careful attention to SBRT and total cumulative EQD2 and embrace guidelines, grade 3 and higher toxicities can be minimized. And to our knowledge, this is the largest cohort of cervical cancer cases treated with curative intent using boot SBRT. So I will say the other time that we use this, when we have patients that present with limited stage 4B disease, so perhaps they had superclab or like an isolated lung met, we will treat them with an interlaced regimen, neoadjuvant, chemo. Oftentimes we'll do a definitive SBRT approach to that metastatic lesion. So to that lung met or to the superclab are the most common one. And then, just as a matter of principle, I do not do interstitial brachytherapy on a metastatic cancer patient. I just feel like that's kind of appropriate. So I do SBRT on these patients, and anecdotally, they have excellent local control. So future directions, and this is where all of you come in. We are considering opening a prospective registry trial using standardized guidelines taken from Embrace for the EQD2 covered as well as the organs at risk to offer SBRT for patients who are unable to receive brachytherapy due to either access to care, medical comorbidities, patient refusal, or technical limitations. So stay tuned for that. We will let you know as soon as we are able to get up and running with that trial. And hope to have everyone's participation in that. So I will open it up for questions. If you could type them in the chat box, that might be easiest for all of us to understand.
Any question from the audience?
In centers with no access to fiduciary markers proposed to use plan of the day. So I have treated patients without fiduciary markers. There are usually something that you can use to align the patient. You do have to have cone beam CT. I don't use the plan of the day for SBRT. We're just not at that point. But usually with bladder filling, and either some calcifications in the patient, or you can visualize the uterus or the rectum. You can usually adjust the table to make sure that you're getting a reproducible plan. I think a plan of the day is probably more of a question for physics, but I think with the dose of SBRT, at this point, I'm not comfortable with using a plan of the day for that yet.
Can you see the tumor from CBCT?
Yes, you can see the tumor, you can see the bladder, you can see the rectum on cone beam. So, what other parameters do you use for dosimetry validation of cervical SBRT? Okay, so here's one thing I didn't mention. So, if you think about brachy, right? You're gonna have a 200% isodose line in the middle of the plan. So for those of you who do brachy, they're very hot plans in the middle. So you have to tell your dosimetrist or your planner. So I usually actually ask physics to plan this. I ask my brachy physicist to plan it because I want it to learn. So I want it to look like a brachy plan. I do not want it super conformal like a lung SBRT. So I want more than like 110, 120% hot spot. I want it really centrally hot. I don't know if it's the same for prostate. I don't treat prostate. I only treat.
It is different. Yeah, it's different. Yeah. For regular SBRT, I believe the hotspot is about 20, most 30%. But you said you can be very hot, right? In the center of target.
Yeah, yeah. Like I wanted to mimic. So when we first started doing this, I would literally draw. So I would draw the pear-shaped distribution for physics. And I would draw the pear-shaped distribution of what the 200% isodose line would look like. Um, literally on so that they would have kind of some idea. Um, more details for cervical SBRT. Um, okay, what details would be helpful? Dosimetry validation. Uh,
You can email me. I can probably give you some document about the symmetry, optimization objectives or goals. Is that you're asking for? Okay. Yeah. Yeah, please email me. I can provide some information. Even though I don't do this planning by myself, but one of our center, we do treat SBRT for cervical cancer. Yeah.
and again, I usually have physics fan this. Just because they're the one that are doing the dosimetry planning, they're the one that are doing the brachytherapy planning. So I want them to think of this as a brachy plan, not a standard SBRT plan where you want to be very heterogeneous and all that, and not have hot spots.
Yeah, looks like this protocol will be, huge benefits for many patients, cervical cancer patients who are not eligible for brachytherapy, right? Especially in many low middle income countries. But first step is trying to develop your SBRT program. Make sure you feel comfortable to use SBRT in your clinic. Yeah.
So I will say this is a very controversial topic.
Mhm.
So we've been first of all, I want to take a minute and say happy birthday to Marie Curie. She is the godmother of radiation oncology. Her birthday is today. And she's really the reason we're all here. So it's appropriate to acknowledge her contributions, especially to brachytherapy. We've been doing brachytherapy now for almost 100 years. It is a very well-established technique. And um, I call it the brachytherapy cartel, because there are those brachytherapy purists in the GYN world that think that there is no alternative. And I assume that's because I have had a hard time getting my SBRT papers published. Because there's a concern that um, SBRT will be watered down to IMRT boost, which we know is not effective. Um, so, and then that SBRT will be done like regular SBRT without the hotspots. And even though there's no actual guidance about the 200% isodose line for the brachytherapist, um, I imagine that those hotspots are probably helpful in terms of getting tumor control. So, there's a lot of concern that physicians who are just um, maybe don't want to do brachytherapy because in the US, brachytherapy is not reimbursed very well. SBRT is reimbursed better. So there's a concern that if this becomes published, people will say, okay, well, we just don't need to do brachy, rather than really using it as an option B for patients who just can't get brachytherapy for whatever reason. So, just be aware that, this is a very kind of controversial topic in the world of GYN cervical cancer.
Thank you so much. If you are interested in this collaboration for respiratory trial, you can contact Dr. Nadawik or myself. And by the way, today is also International Day of Medical Physicists. So yeah, International Day of Medical Physics. So yeah, congratulations and a happy International Day. And next session will give some demo for treatment planning for SBRT. If you have an interesting case, you want us to present in real time, give a demo, please let me know. But you need to send me the CT and also structures. So I will, either me or one of our dosimetrists will present or give a demo on how to plan SBRT case. If I don't receive any cases from you, we're going to use our own case. So today we're going to finish earlier. I know another week need to go to another meeting or lecture. So if you have any question, feel free to reach out.
So I put my email in the chat. I'm not a physicist. I'm not a dosimetrist. I'm just a physician. So any really technical questions, I'm gonna have to pawn off on somebody smarter than me. But I would at some point like some volunteers for input as we work on designing the registry trial, because I want the trial to be able to have a certain amount of QA and documentation, but I don't want it to become prohibitive to enrollment. So I would really like to have a couple of volunteers that would be willing, that are interested in participating in the trial, that would be willing to be kind of a focus group for us to help me understand the feasibility of, DICOM file transfer, of uploading coverage, constraint, filling out the BED sheet, that kind of thing. So that would really help me in developing a trial that is kind of a good mix of getting good dosimetric information, but also not being too time consuming and prohibitive for the centers participating.
So what's the timeline for this registry trial, and how many patients or how many sites or countries you are going to involve?
I haven't gotten that far yet. We just had
Okay.
the idea yesterday. So I kind of working on that. I've never opened an international registry trial, so there's gonna be a little bit of legwork from me in navigating the IOB process. Um
Right. Yeah.
so
I know Kauma, maybe Solomon is also here. I think we had a brief conversation before. I think they have quite a lot of patients who are not eligible for brachytherapy in Uganda. Binjima is also here from Mongolia, and probably some other doctors from different countries. And probably can reach out to you if they have any question or interest in this clinical trial. Yeah.
fantastic. Well, thank you so much for having me today, and please feel free to contact me if there's any kind of clinical questions that I can help with.
Okay. Thank you very much. Let me try to stop.